Welcome to online anesthesia video of the week. Today topic is presented by Dr. V.VISSNUKUMAR MD P.D.C.C, working as a consultant pain physician, SCS Hospital Hosur, Tamilnadu. He has earned his master degree in anesthesia from King George Medical College, Lucknow, Uttar Pradesh. He has so far published 5 papers in various reputed journals and presented 7 paper and poster in conferences. His areas of interest: minimally invasive percutaneous pain and spine interventions, and endoscopic discectomy.
A very good day, everyone. For the next few minutes, we'll be talking about stellate ganglion block. I am Dr. Vishnukumar, pain physician, practicing at Sri Chandra Sekara Hospital, Hosur. We'll start with the basics. The autonomic nervous system consists of sympathetic and parasympathetic counterparts. The sympathetic nervous system is responsible for fight or flight response. So, when you see the sympathetic trunk, this sympathetic trunk extends vertically on both the sides of the vertebral column. Okay, so you can see from the base of the skull, it travels to the cervix, cervical region, thoracic region, lumbar region, sacral region, and ends at the coccyx, forming the ganglia impar. So the sympathetic trunk extends vertically on both sides of the vertebral column from the base of the skull down to the coccyx. So it consists of enlarged structures which are called as ganglia, and these enlarged structures are connected by nerve roots which are called the sympathetic trunk. Okay. So, the sympathetic trunk basically contains the preganglionic fibers and the postganglionic fibers. So, the sympathetic trunk contains preganglionic and postganglionic fibers. The preganglionic fibers originate from the intermediate lateral cell column of the spinal cord of the thoracic and the lumbar segment. So you can see it originates from the intermediate lateral column of the thoracic and the lumbar region, that is from T1 to L2 level of the spinal cord, and they exit the spinal cord through the ventral roots. As you can see in the diagram, the sympathetic preganglionic fibers exit through the ventral root and enter the sympathetic trunk via the white rami communicants. The postganglionic fibers, after synapsing in the ganglia, the postganglionic fibers emerge and innervate the target organs, the blood vessels, skin and glands throughout the body. Okay. So, the sympathetic trunk and the sympathetic nervous system plays an important role in neuropathic, visceral and vascular pain. So, if a patient is suffering from stomach pain secondary to carcinoma stomach, they undergo a sympathetic plexus block called a celiac plexus block because it is a visceral pain. So as a result, the blockade of this sympathetic system counterparts can be helpful for a variety of painful and non-painful medical conditions. A temporary blockade of the sympathetic nervous system can help to differentiate sympathetically maintained pain from sympathetically independent pain. So the sympathetic nervous system innervation is an important 5-mark question for the MD anesthesia residents. So where does the sympathetic chain originate? It originates from the intermediate lateral horn of the T1 to L2 level of the spinal cord. So now what happens? You can see this is the spinal cord. Here you have got the dorsal root and ventral root. They form the spinal nerve and they form the dorsal ramus and ventral ramus. So the sympathetic preganglionic fibers travel through the ventral root, they come to the ganglia. So as soon as they come to the ganglia, here you can see the sympathetic ganglia and which is interconnected by the sympathetic train. As soon as they come to the ganglia, they synapse at the same level. That is, the postganglionic fibers, they synapse at the same level and the postganglionic fibers emerge at the same level and it will innervate the skin and the blood vessel. So now what happens, sometimes the sympathetic preganglionic fibers will come here and directly they pass through the sympathetic trunk and they terminate in the ganglia above or below, so that they can innervate the postganglionic fiber. They will synapse with the postganglionic fibers there, and the postganglionic fibers will try to innervate the skin and the blood vessel over the concerned level. Sometimes what happens, there will be no synapses in the ganglia. The preganglionic fibers directly bypass the sympathetic ganglia and they terminate in the ganglia which is present near the organ. For example, they synapse in the distant collateral ganglion anterior to the vertebral column. Let us consider for an example the celiac ganglion. The celiac ganglion, what happens? The sympathetic fibers directly bypasses the sympathetic ganglia and terminate in the celiac ganglion, and thereby they supply the visceral organs of the abdomen. So this is how the neural pathways to the sympathetic chain ganglia works out. So now the anatomy of the cervical sympathetic chain. The sympathetic fibers for the head, neck and upper limbs and the heart arise from the first few thoracic segments, so namely from T1 to T4. And what happens? They ascend through the sympathetic chains and synapse in the superior, middle and inferior cervical ganglia. So here you can see superior, and here you can see middle, and here you can see the inferior cervical ganglia. So what happens? From T1 to T4, the fibers are going above, they are synapsing here, and from here the postganglionic fibers are going to innervate the head, neck, upper limb and the heart. That's why when a patient is having a pain in the heart, sympathetically mediated pain, you call it as a referred pain. That is not a pinpoint pain like a somatic pain where there is an injury to the soft tissue. So what happens? There is a common sympathetic innervation between the upper limb and the heart. So upper limb sympathetic innervation is from T1 to T3 and the cardiac sympathetic innervation is from T1 to T4. So whenever you get a myocardial infection, what happens? The pain is radiating from the heart, it is going to the neck and it is also going to the upper limb. That is the importance of the sympathetic innervation. Okay. So this stellate ganglion. So what do you mean by stellate ganglion? This stellate ganglion is formed by the fusion of the inferior cervical and first thoracic ganglion. So here you can see this is the superior cervical ganglion, this is the middle cervical ganglion, and this is the stellate ganglion, which is formed by the fusion of the inferior cervical and first thoracic ganglion, and it extends from the level of the head of the first rib. Here you can see the first rib to the inferior border of the transverse process of the C7. Okay, this is the sun, and it lies medial or sometimes posterior to the vertebral artery. So here you can see this is the vertebral artery and this is medial, and the stellate ganglion is medial and posterior to the vertebral artery. So as you can see, this is the superior cervical ganglion, this is the middle cervical ganglion. Here you can see the inferior cervical ganglion and the stellate ganglion, which is in close proximity to the dome of the pleura. Okay. So now excuse me. So we are going to see the pictorial illustration of the stellate ganglion. Here this is the star-like structure. This is nothing but the stellate ganglion, which is formed by the fusion of the inferior cervical ganglion and the first thoracic ganglion. So you see the stellate ganglion is exactly present anterior to the C7 and T1 transverse process, and it is present over the lateral surface of the vertebral body, and it is above the longus colli muscle. So this stellate ganglion, if you see, it is star-shaped structure, fusiform structure. Stellate means fusiform structure, and it has many important correlations. So the most important thing is the stellate ganglion is associated with the very crucial structures. For example, here you can see the vertebral vessels. Normally if you see the vertebral artery, so these are the vertebral artery and the vertebral vein. The vertebral artery usually ascends and enter the foramen in the transverse process of the C6 vertebra. And here you can see the C6 vertebra, and here you can see the vertebral artery and vertebral end entering into the foramen transversorium. Okay, so it is outside the foramen transversorium at the level of C7, and it is at the level of C6, it is inside. So now this stellate ganglion is in close proximity to the vertebral vessels, the vertebral artery and the vertebral vein. Again, you see there is an aberrant artery called the inferior thyroid artery, and even the inferior thyroid artery is also very close to the stellate ganglion. So as far as we see, the stellate ganglion is surrounded by crucial structures like vertebral artery and vertebral vein, inferior thyroid artery here. So performing, and behind we do have a pleura of the dome of the lungs. Okay, so performing a stellate ganglion block at the level of C7, it is not possible at all, because when you do at the level of C7, there is a high possibility of injuring the adjacent structures. You can injure the pleura, you can injure the blood vessels. So if you injure, then immediately the patient will have local anesthetic toxicity. So now what do we do is, we often perform stellate ganglion block at the level of C6. So the main advantage is that, see, when you do at the level of C7, we have so many neural structures and vascular structures, so it is not practically possible to do that. And besides, previously stellate ganglion was given fluoroscopic guided, and sometimes before that they were giving landmark technique. So this is practically not possible because of the presence of numerous vascular structures, and this complements the use of ultrasound for real-time visualization of the blood vessels and nerves, so that you can directly inject the local anesthesia over the stellate ganglion. So to counteract this, what we do is, we actually perform a stellate ganglion block at the level of C6. We deposit our local anesthesia just above the longus colli muscle under real-time ultrasound guidance, and once we deposit there, the local anesthesia just spreads down and blocks the stellate ganglion, which is present at the level of C7T1. Okay. So as you can see in the cross-sectional anatomy, this is the longus colli muscle, which is present in the present over the anterior lateral part of the vertebral body of the cervical vertebra, and just lateral to the longus colli muscle we do have the scalene muscle. You can see anterior scalene muscle. Okay, on either, this is the longus colli and this is the anterior scalene, and this is covered by the prevertebral fascia, and this yellow like structure is the sympathetic trunk, stellate ganglion, that we are intended to block. So now this sympathetic trunk is present between the carotid sheath and the prevertebral fascia. So our main job is to deposit the local anesthesia at this level, so that we get an efficient and the successful block. So as indicated by the arrow, this is the cervical sympathetic trunk, the stellate ganglion, so where we deposit the local anesthesia. So the preganglionic fibers of the head and neck region continue to travel cephalad to the superior and middle cervical ganglion through the cervical sympathetic trunk. The postganglionic fibers from the stellate ganglion through the cervical nerves, mainly C7 and C8, and with the T1 provide sympathetic innervation to the upper lip. So injection of local anesthesia around the stellate ganglion will interrupt the sympathetic outflow to the head and neck and upper limbs through inactivation of both preganglionic and postganglionic fibers. Okay. So now how we are going to perform this stellate ganglion block. So usually what we do is, I do perform cervical stellate ganglion block under real-time ultrasound guidance using a 20 gauge needle. So when I perform, I used to ask my patient to turn the head towards the opposite side, and I'll keep a pillow below the head, providing slight neck flexion to aid proper visualization of the image and provide no hindrance to my needle trajectory. So, while performing the stellate ganglion block, it is essential to identify at which level you are. You are basically, we told that you should not perform block at the C7 vertebra. You should always perform block at the C8 vertebra, because this is the foramen transversarium and the vertebral artery enters into it. But here at the level of C7, the vertebral artery is in close proximity to the stellate ganglion. Okay. Now, how will you identify these two vertebrae? So if you see, this is the transverse process, and this transverse process has an anterior tubercle and the posterior tubercle, whereas in the C7 vertebra there is no anterior tubercle, we do have only posterior tubercle. So by identification of the tubercle, we can definitely say at which level we are. Let us see how we are doing. So when we keep the probe, so you can see this is the image that we get, and this is the angulation through which we keep our probe, and this is the image that we get. So what is this? This is the anterior scalene muscle, and here we have got longus collae muscle, and this is the sympathetic chain. But problem is that, can you see, this is the transverse process of the C7. Here you have got the C7 nerve root, and this is the vertebral vessel. Okay. Now, when you deposit drug here, what happens? There is a more chances of injuring the vertebral artery. So even 0.2 ml of local anesthesia, if it enters into the vertebral artery, it will directly go to the brain, and the patient will have local anesthesia systemic toxicity. The patient will have seizures, and it is really a life-threatening condition. So what do? This is at the level of C7. Now we have to identify C6 level. So here you can see at the level of C7, this is the yellow one is the C7 nerve root, and the red one is the vertebral artery and vertebral vein. And at the level of C6, the vertebral artery and vertebral vein is entering into the foramen transversarium, and now the nerve root is present between the anterior tubercle and posterior tubercle. Okay. So at this level, we can prevent the injury to the mainly vertebral vessels, thereby reducing the incidence of local anesthesia systemic toxicity. So again here you can see this is the C7 transverse process containing only posterior tubercle. There is no anterior tubercle. Here you have got C7 nerve root and the sympathetic trunk here. When I bring my needle under real-time ultrasound guidance, if I deposit my local anesthesia, there is a high chance that my vertebral vessels are going to get injured. Okay, so we do not do at this level. We try to move cephalad to identify the C6 vertebral body. Now as I move cephalad, can you see this one? This is the posterior tubercle, and now this is the anterior tubercle. So this is the longus collae muscle, and this is the cervical sympathetic trunk. This is the carotid that we are going to visualize. So now we are at the level of C6. So this is the anterior scalene muscle, and this is the longus collae muscle, and the one which is green is the prevertebral fascia, and this is where you have to deposit the local anesthesia. So like this it comes, and you will be depositing the local anesthesia. Okay. So let us see the real-time ultrasound visualization, how we are going to deposit. So here this is the real-time ultrasound image. So here you can see the C7 transverse process, which is absolutely flat, and now you can see the nerve roots. Which nerve roots? These are the C5 and C6 nerve roots, and this is the C7 nerve root. Now what is the problem? Here we have got vertebral artery and vertebral vein. Now can we perform a stellate ganglion block here? So no. Why? Because we are going to, this is the longus collae muscle, and when you place here, directly you will be damaging the vertebral artery and vertebral vein. So now what do? You just move cephalad, and as you move the probe cephalad, you can see two structures. What is this? I'm sorry. I'm extremely sorry. So this is the C7 region, and as you move cephalad, what happens? You can see two structures. Okay. So So this is the posterior tubercle and this is the anterior tubercle, and you have C6 nerve root. Okay. So now once you reach at the C6 level, you place a Doppler to ensure that there is no vertebral artery, because sometimes what happens, the vertebral artery can be outside the foramen transversarium at the level of C6 as well. They can enter into the foramen transversarium at the level of C5. So what happens, always when you perform, before giving the block, use a Doppler, ensure that there is no blood vessel in the trajectory that you are going to give injection. Okay. So now once you are confirmed with that, here this is a very beautiful diagram. You can see this is the C6, this is the posterior tubercle, this is the anterior tubercle. Okay, this is the transverse process, and here you can see this longus colli muscle, and this is the anterior scalene muscle. And now what we do, directly I'll be bringing my needle. So you can see my needle trajectory. This is my end point here. Okay, and as I bring my needle, I'll be depositing the local anesthesia. Here you can see the spread of the local anesthesia now. Okay, so once I used to give for a diagnostic block, I used to give around 5 ml of the local anesthesia. Now we saw what is stellate ganglion block very briefly, and now what are its indication. So it can be used for painful medication and non-painful medication conditions. So if the patient is having sympathetically mediated pain of upper extremity, head or neck, for example, in the head the patient can suffer from post-herpetic neuralgia. In upper extremity they can suffer from CRPS, complex regional pain syndrome. That is, the patient would have got fracture few months before, and now he will be complaining of severe pain which is not proportionate to the inciting event. So acute herpes zoster or post-herpetic neuralgia of the head, neck and upper thorax. Phantom limb pain is the most common thing which you will be getting in your practice. Cluster headache or atypical vascular headache. Intractable angina pectoris. The patient will be having a severe anginal pain, but the patient will have, they call it as atypical chest pain. You would have done a TMT would have been a negative, tropi would have been a negative. Sometimes they used to do a coronary angiogram as well, and they will come to me saying that the patient will be having chest pain. For those patients, we do perform stellate ganglion block. For non-painful medication, I would first directly say, whenever a vascular surgeon performs a AV fistula, sir will ask for a blockade of stellate ganglion also. So what is that importance? So whenever you are giving the stellate ganglion block, the sympathetic vasomotor tone of the blood vessel is being reduced. So once you reduce the sympathetic vasomotor tone, the blood vessel will dilate, and that will help them for easy anastomosis. Another condition for Raynaud's disease, obliterative vascular disease, vasospasm, hyperhidrosis, lymphedema, refractory ventricular arrhythmia. So we have got multiple publications regarding refractory ventricular arrhythmia where we use stellate ganglion blocks as a last resort for the treatment. So even it has been used in the post-traumatic stress disorder as well. These are the common indications for which the stellate ganglion is used. So contraindication. So anticoagulated patients or those patients who are suffering from coagulopathy, pre-existing contralateral phrenic nerve palsy. So if there is a contralateral phrenic nerve palsy, we should not give a stellate ganglion block, because there is a high possibility of drug damaging the phrenic nerve. We will see in the next slide in the complications one. And if the patient is having recent myocardial infarction, giving a stellate ganglion block is going to be a disaster, because it is going to completely cut down the sympathetic supply to the heart. Thereby it can reduce the chronotropic support and inotropic support of the heart also. And those patients who have cardiac conduction block, no, never give stellate ganglion block, and only unilateral block should be performed to avoid bilateral recurrent laryngeal nerve block and resulting stridor. Okay, so this is a one simple diagram which is explaining all the complications. So now what happens, this is the structure of interest. This is the longus colli muscle and this is the sympathetic trunk. And now when you are blocking this stellate ganglion, you're blocking the sympathetic chain, and so you will be getting the Horner syndrome. Within the carotid sheath, we have an internal carotid artery, and we have got a carotid artery, and we have got an internal jugular vein and vagus nerve within the carotid sheath. Sometimes when you penetrate the carotid fascia and the local anesthesia, if it deposits there, you can cause damage to the vagus nerve also. And sometimes damage to the blood vessel can cause hematotoxicity or hematoma or toxicity, local anesthesia, systemic toxicity. So above here we have got recurrent laryngeal nerve, which is going to give you dysphonia. And sometimes in lean and thin patients, the esophagus, this is the esophagus, you can damage there is a high probability of damage the esophagus, airway injury or the thyroid injury as well. And now as the drug seeps out posteriorly, you can block the brachial plexus, which is present between the scalenus muscle. And if you give overdose, usually I will not cross more than 5 ml. If I am giving more than 5 ml, there is a high chances of neuraxial blockade or injury as well. Okay. So these are some clinical pearls which I got from my experience. So when performing cervical levels, make sure to scan in a caudal and cephalad direction to identify both C6 and C7 levels. Always use colored Doppler to assess for the location of the vertebral artery and other major vessel that may lie in the path of the needle. In 7 to 10% of the patient, the vertebral artery will be exposed outside of the foramen transversarium at the C6 level. So always use a Doppler. So place a normal saline bag underneath the ipsilateral shoulder to allow more space for the hand holding the needle for in-plane technique, which we normally use for the interscalene block. So always before you give local anesthesia, do an hydrodissection with the normal saline, because it will help minimize the risk of unintended intravascular injection with the local anesthetic. So due to the proximity of the central venous system, small amounts of the local anesthetic injected intravascularly can quickly lead to complications such as seizures, and perform only unilateral injections to avoid risk of respiratory complications associated with the bilateral injection such as phrenic nerve palsy and swallowing difficulties. Patient should be made aware of what can be expected post injection. This is very, very important. See, always whenever you are blocking a sympathetic trunk, the patient is going to get an Horner syndrome. They will be having ptosis, meiosis, anhidrosis. So even of course the pain loss will be there, and it will be associated with the facial and conjunctival flushing. There will be upper extremity numbness if it is going to affect your brachial plexus, or it can cause hoarseness and dysphagia when the recurrent laryngeal nerve is going to be affected. The Horner syndrome following the procedure can be used as a confirmatory sign of a successful blockade. Okay. So a short case history. This is the recent case which I have done. 55 years male. I had a severe right-sided facial pain over the past 2 years. Here you can see the lesions, and he was being diagnosed as a case of post-herpetic neuralgia. He is not relieved with any anti-neuropathic or analgesic medications. He was on multiple morphine, pregabalin, gabapentin, all those drugs. He has also attempted suicide twice. For this patient, when he presented to my OPD, we have given like stellate ganglion block initially, diagnostic block. Post block he had got like 90% relief, and once he came off after 2 weeks, we did an radiofrequency ablation for stellate ganglion block towards his right side, and now the patient is living happily with a very small dose of anti-neuropathic drugs. So thanks God for giving excellent relief for this patient. So thank you very much for your patient listening. So purposefully I've asked this topic to Edward Johnson sir because I just wanted to instill some knowledge of what pain procedures the pain physician do, so that I want to aspire some young enthusiastic PGs who are interested in pain medicine, and it is a wonderful career. And if you have any queries, you can please mail me and you can ask me anytime. So a most important question, previously old examiners, they are very fond of asking celiac plexus block, the anatomy, but now the celiac plexus block is obsolete. No one is using it. And stellate ganglion block has been nowadays used widely, Apart from the painful medical condition, it is also used for non-painful medical condition, as we have discussed. So I hope this can be asked as a 5-mark question in an exam as well. So I just wanted to give a brief idea of what is stellate ganglion block. Thank you for the opportunity. Thank you for your patience listening. Thank you.